In this presentation, we'll be discussing hearing disorders. This lecture was written by our visiting professor, Dr. Beverly DeGrandchamp. Dr. DeGrandchamp is a board-certified family nurse practitioner and has a doctorate of nursing practice degree. She's been a nurse practitioner for 18 years and in the nursing field for over 40. She currently does local tenens assignments all over the nation and has worked in a variety of settings. Narration is provided by Dr. Tracy Murray. Welcome to this lecture covering the ENT system as it relates to hearing disorders. While not all ENT topics are discussed, we'll cover several of the most commonly seen in primary care. These discussions should provide you with a framework to develop a differential and formulate an evidence-based medicine treatment plan. This lecture corresponds with Chapter 8 in your textbook, so please be sure to review it before this lecture. I cannot stress enough the importance of obtaining a detailed history of the problem or the complaint of a patient. This is a critical piece in developing your differential diagnosis for any condition or disease. A good history taker makes for a highly competent diagnostician. Questions you ask should be documented in the record to substantiate the reasons you may order a test or advise a patient in their treatment plan. Now let's discuss two types of hearing loss, conductive and sensorineural. Sensorineural hearing loss results from deterioration of the cochlea, usually due to loss of hair cells from the organ of chordate. This is very common in adults. Sensorineural hearing loss is gradual, progressive, predominantly high-frequency loss with advanced aging, otherwise known as presbyosis. Other causes include ototoxic drugs, noise exposure, head trauma, autoimmune disorders, and metabolic disease or acoustic neuroma. Genetic makeup can have influence over these hearing losses. Sensory hearing loss is not correctable with medical or surgical therapies, but often can be stabilized if the hearing loss is not sudden. Sudden hearing loss may respond to corticosteroids if delivered within several weeks of onset. Identification of sensorineural hearing loss is usually made by performing audiometry, in which bone conduction thresholds are measured. Tympanometry and speech audiometry may be helpful. Testing is performed by an audiologist. There is no proven or recommended treatment or cure for sensorineural hearing loss. Management of hearing loss is usually by hearing strategies and hearing aids. In cases of profound or total deafness, a cochlear implant is a specialized hearing aid which may restore a functional level of hearing. Conductive hearing loss is a result of obstruction between the middle ear and outer ear. This can occur with cerumen accumulation or impaction, a foreign body in the ear canal, otitis externa, chronic otitis media, middle ear effusion, otosclerosis, which is scarring of the tympanic membrane, a vascular anomaly, or a cholesteatoma. To treat conductive hearing loss appropriately, an etiology must be accurately identified. Most types of conductive hearing losses are reversible. A quick bedside test that can be done to differentiate sensorineural versus conductive hearing loss is the Weber and Rinne test. This is a valuable screening tool that primary care providers tend to underutilize. The Weber hearing test evaluates lateralization, so if hearing is better on one side or the other, and it involves placing a vibrating tuning fork midline on the top of the head and equidistance between the ears. The patient's asked to report in which ear the sound is heard louder. A normal Weber test will result in the patient hearing the sound equally on both sides. In sensorineural loss, the patient reports that the normal ear hears the sound better, so sensorineural hearing loss is on the defective side. In a conductive loss, the patient reports that the defective ear hears the tuning fork louder. The Rinne test evaluates air and bone conduction hearing loss and involves placing a vibrating tuning fork initially on the mastoid process behind each ear until sound is no longer heard. The fork is then immediately placed just outside the ear, and the patient's asked to report when the sound caused by the vibration is no longer heard. A normal test is when the sound heard outside the ear is audible, and the sound from over the mastoid bone can no longer be detected. In other words, air conduction is louder than bone conduction. In conductive hearing loss, bone conduction is greater than air conduction, so the patient will report the bone conduction sound longer than the air conduction sound. Cerumen impaction is a very common occurrence in primary care. Cerumen is the protective secretion produced by the outer portion of the ear canal. Most impactions occur from persons who try to clean the canal improperly with Q-tips. Therefore, recommended hygiene instructions should consist of cleaning the external opening with a cloth over the index finger only. Cerumen impactions can be removed by detergent eardrops such as over-the-counter Debrox or Cerumenex, and mechanical removal, including over-the-counter kits that have a bulb syringe. Many primary care provider offices provide irrigation and manual removal under otoscopic examination. Water used should be body temperature in order to avoid dizziness. Irrigation should only be done if the provider is sure the tympanic membrane is intact and the external canal is not infected. Having the patient pre-treat with detergent eardrops for 3 to 5 days prior to irrigation is particularly helpful when the cerumen is hard. Foreign bodies in the ear canal are more common in children than adults. Small pieces of toys, crayons, beads, and eraser tips are commonly seen. In adults, cotton pieces from a Q-tip may be found lodged up against the tympanic membrane. Material that is firm may be removed with a hook or loop, being careful not to push it back into the tympanic membrane. If manual removal is unsuccessful in your office, a referral to an ENT for suction removal is warranted. Insects in the canal are also common and removal can be challenging. Live insect movement and sounds can be very painful and uncomfortable. By placing a drop or two of mineral baby or olive oil inside the ear canal, the insect can be killed, providing a significant amount of relief. Some ED providers use xylocaine to paralyze the bug. This can help you to avoid stinging or eardrum rupture from scratching or biting. If the insect does not come out easily with manual removal, refer the patient to ENT. Insects that don't come out easily can result in small pieces being left behind. Tympanic rupture may result from impact injury, rapid pressure changes as from airplane travel or explosive acoustic trauma. Acute infection of the middle ear may cause a relative ischemia in the drum concurrent with increased pressure in the middle ear space. This leads to a tear or rupture of the eardrum that is usually preceded by severe pain. If the perforation does not heal, it leaves a residual tympanic membrane residual, which is called TMP. Patients will report sharp ear pain that will reside quickly, drainage and ringing in the ear or hearing loss. Spontaneous healing occurs in most cases. Treatment can include antibiotics, an eardrum patch, or surgery might even be necessary. Otosclerosis is scarring of the tympanic membrane that can occur after a rupture has healed or after tympanostomy tubes have fallen out and the membrane has sealed itself. Otitis externa is quite common in the primary care setting. Otitis externa is an inflammation of the membranous lining of the auditory canal. The condition is typically benign and self-limiting, but very painful. Invasive otitis externa, including malignant otitis externa and necrotizing otitis externa, can be potentially life-threatening if left untreated. Persistent cases of acute otitis externa in diabetic or immunocompetent patients may evolve into osteomyelitis of the skull base, and this is considered a medical emergency. That important history taking often reveals recent water exposure or mechanical trauma, such as scratching with keys and other objects. Causes of infection in most cases are gram-negative rods, such as Pseudomonas or fungi, from excessive moisture. Patients will typically present with a painful pruritic ear and usually with conductive hearing loss. The external canal will appear red and swollen, often with purulent drainage. Manipulation of the auricle often elicits pain. Because the lateral surface of the TM is ear canal skin, it's often erythematous also. When the canal skin is very edematous, it may be difficult to visualize the TM. Treatment of acute otitis externa involves protecting the ear from any more moisture and avoiding further mechanical injury from scratching. Antibiotic otic drops should be administered with or without corticosteroids. Certain classes of antibiotic drops have not been shown to be superior over the others, so formulary, cost, and convenience should be taken into consideration. It's important to note that if the tympanic membrane cannot be visualized, only fluoroquinolone drops should be used as they're not ototoxic. Uncomplicated acute otitis externa commonly resolves after 7 to 10 days of topical treatment. Drops should be used abundantly to penetrate the depths of the ear canal. A wick can be placed to facilitate the entry of the medication. Now, cases that are refractory to initial therapy or involve auricular cellulitis require systemic antibiotic treatment covering both Pseudomonas and Staph aureus. More serious external ear canal conditions may need oral or IV antibiotics, and a referral is warranted. Another common condition causing conductive hearing loss is Eustachian tube disorder. Anatomically, the Eustachian tube connects the middle ear to the nasopharynx. The purpose of the Eustachian tube is to protect the middle ear from nasopharyngeal secretions, equalize pressure across the tympanic membrane, and clear out middle ear secretions. Eustachian tube dysfunction is a disorder where the Eustachian tube is unable to properly regulate air pressure inside the middle ear and/or effectively drain secretions from the middle ear cleft. Dysfunction may involve a reflux of nasopharyngeal secretion in the middle ear or due to a variety of pathophysiological changes that in some way impede the normal opening and closing of the Eustachian tube. Some of the most common causes include conditions causing nasal congestion, as seen with allergic rhinitis, sinusitis, upper respiratory infections, enlarged adenoids, and pregnancy. Additionally, those who have recently traveled in an airplane or who have been scuba diving are more at risk for Eustachian tube disorder. With Eustachian tube disorder, often people complain of decreased hearing or a fullness in the ears. Hearing may be muffled or diminished. They may report an inability to pop or clear their ears, which normally occurs with changes of barometric pressure. They may have accompanying tinnitus or disequilibrium. Patients may come to you thinking that they have an ear infection due to pain or the pressure. They may also be concerned of cerumen impaction if they're experiencing hearing loss. The differential for Eustachian tube disorder should include the following: acute serous or chronic otitis media, otitis externa, cerumen, viral meningitis, cholesteatoma, and otosclerosis. Physical exam findings with Eustachian tube disorder depend on the precipitating event. Nasopharyngeal examination may reveal findings consistent with allergic rhinitis, sinusitis, or upper respiratory infection. On the affected side, typically you'll see a TM that appears retracted or sucked back. Notice the prominent malleolus in this picture. Effusion may or may not be present with Eustachian tube disorder. Diagnosis of Eustachian tube disorder is based on the history and physical exam. If pneumatic otoscopy is performed, the affected TM will be immobile. A Weber and Rinne hearing test will reveal conductive hearing loss on the affected side. The key to successful treatment of Eustachian tube disorder is to treat the underlying problem. If the problem is a cold, then nasal saline drops or a neti pot may help. Acute otitis media and sinus infections are treated with antibiotics. Allergic rhinitis should be treated with nasal steroids and decongestants. However, decongestants are contraindicated in children under 6 years of age, and should be used in caution with people with hypertension or cardiovascular disease. Comfort measures can include acetaminophen or ibuprofen, and patients should be instructed to attempt to relieve pressure by yawning, chewing, or sucking. Holding the nose and blowing out is not recommended due to the risk of TM perforation. For chronic Eustachian tube disorder that is unresponsive to treatment, an ENT referral is warranted. In some cases, tympanostomy tubes may be placed to equalize pressure. Now let's talk about sensorineural hearing loss disorders that you may encounter in your practice. Tinnitus is defined as a sensation of sound in the absence of an exogenous sound source. It may be intermittent, continuous, or pulsatile. The causative mechanism is poorly understood. A few theories include chronic exposure to noise, especially high-pitched sounds, that may damage the cilia and auditory hair cells or spontaneous activity in individual auditory nerve fibers. Tinnitus is strongly associated with age and hearing loss, but it can also be the result of many underlying conditions that include, but are not limited to, an infectious origin, metabolic disorders, autoimmune disorders, head or ear trauma, ototoxic medications, vascular, or neurogenic causes. Most patients are not bothered by tinnitus when they're surrounded by their usual sounds of everyday life. However, when in a quiet location, the perception of tinnitus may be profound. The sound is often described differently by patients. It may be described as the sound of escaping air or running water, or the sound heard inside a large seashell. It may be described as buzzing, ringing, humming, hissing, popping, roaring, or pulsatile, to name a few. The sound can be loud or soft, low-pitched or high-pitched, coming from one or both ears. Tinnitus may cause emotional distress and anxiety, and gradual loss may lead to complete deafness. The differential for tinnitus should include the following: Meniere's disease, acoustic neuroma, otitis media, otosclerosis, cerebral vascular disease, and salicylate overdose. Physical exam for a patient with complaints of tinnitus should include orthostatic blood pressure readings, gross hearing test or a whisper test, as well as Weber and Rinne test to detect conductive versus sensorineural hearing loss. A thorough otologic exam with pneumatic otoscopy should be performed. Diagnosis can be difficult and involves determining the etiology. The workup involves taking an important history as well as the physical exam. Basic laboratory tests to evaluate for metabolic abnormalities include TSH, CBC, B12, and lipid panel, and should be performed by the primary care provider. If a metabolic cause cannot be identified, a referral to ENT is appropriate for further workup and specialized testing needed to establish the etiology. Additional workup may include audiometry and tympanometry. Imaging studies such as CT, MRI, or MRA, and venography may also be needed to make a diagnosis. Tinnitus is difficult to treat successfully. However, management of symptoms and treatment of the underlying disorder, if one can be identified, may help. Elimination of possible offending medications such as aspirin or NSAIDs is a priority. Patients with tinnitus due to otitis media or infections should be treated with antibiotics for an adequate duration. Although there has not been a medication found to help tinnitus, oral antidepressants may be effective in reducing symptoms. Nortriptyline or Elavil 50 milligrams at bedtime is often used. Meclizine or Antivert is a commonly used vestibular suppressant. It's important to note, however, that there's no evidence to support the use of any medication, vitamin, or nutritional supplement in the treatment of tinnitus. If the patient is severely emotionally disturbed by the sound, a referral to a psychologist or otolaryngologist is recommended. Moving on to our next topic. Meniere's disease is a condition that you need to be able to recognize in primary care. Meniere's disease is a sensory disorder of both the labyrinth, or the semicircular canal system, and cochlea of the inner ear. The precise cause of Meniere's disease is not fully established, but theories have implicated the inflammatory response of the inner ear due to a variety of insults, including blunt trauma, viral infections, allergies, reduced or negative middle ear pressure, and various vascular, endocrine, and lipid disorders. A genetic predisposition has also been suggested. Migraine headaches, autoimmune conditions, and certain thyroid disorders may predispose patients to Meniere's disease. Acute episodes of Meniere's disease are associated with the characteristic triad of symptoms: vertigo, hearing loss, and tinnitus. Acute attacks can last from 20 minutes to 3 hours, and their frequency and severity of attacks may decrease over time. Hearing loss is typically low-frequency loss and may improve immediately after an acute attack. The differential for Meniere's disease should include the following: otitis media, vestibular neuritis, benign paroxysmal positional vertigo, acoustic neuroma, CNS lesions, or acute vestibular labyrinthitis. Diagnosis of Meniere's disease is based on history and is a diagnosis of exclusion. Otoscopic exam is generally normal unless underlying otitis media is present. A Weber and Rinne hearing test will reveal sensorineural hearing loss on the affected side. Diagnosis can be difficult and involves determining the etiology. The workup involves a very important history as well as a physical exam. Basic laboratory tests to evaluate for metabolic abnormalities include the TSH, CBC, B12, and lipid panel, and should be performed by the primary care provider. If a metabolic cause cannot be identified, a referral to ENT is appropriate for further workup and specialized testing needed to establish the etiology. Additional workup may include an audiogram, an electronystagmography, electrocochleography, vestibular evoked myogenic potential, and MRI to rule out acoustic neuroma. And finally, let's discuss treatment for Meniere's disease. Acute attacks are best treated by bed rest with the eyes closed and protecting from falling. Attacks rarely last more than 4 hours. Pharmacological therapy, if necessary, is directed at symptomatic relief. Maintenance therapy with a mild diuretic such as chlorothiazide or diurel, 500 milligrams per day, is often used. The theory is that a reduction in lymphatic pressure and volume may improve symptoms. Meclizine, promethazine, diphenhydramine, or metoclopramide are also advocated. Of note, these treatments are most effective for vertigo symptoms, whereas tinnitus and hearing loss are less effective.